This program is brought to you by the Forbes-featured Freedom Hub Health Plan, the alternative to overpriced and restrictive insurance. The Freedom Hub Health Plan is exactly what you need. By Frequency Medicine Associates, supporting health professionals and laypersons with safe and effective advanced telemedicine-like technology that can scan and help rebalance the root causes of stress and illness. By the Planet Lockdown film, which can be seen on the Freedom Hub's Rumble channel along with many great speakers. And by The Pavilion, a 21st century community hub that brings together many of the disruptive innovations featured by the Freedom Hub, including direct pay healthcare, farm-to-table dining, TED-like Freedom Hub talks, and more. Visit your-mp.com/pavilion solution for details. Welcome to Freedom Hub Health, Biz, and Politics. It's December 14th, Wednesday, and we have a good show today. If you're new to the channel, your-mp.com is our website, and go to the home tab down to webinars, and you will see who's coming up this week, each week, Wednesday and Thursday. Our Health, Biz, and Politics program and our Freedom Hub program on Thursday. Down at the bottom are our channels, BitChute, Brighteon, etc., where you can get the access to the videos afterwards. Usually they're posted on the weekend, Monday at the latest. And up here, we do recommend you subscribe to the channel so you get the regular announcements. And with that, Charlie, why don't you introduce our guest and topic today?
Gladly. Dr. O'Rourke, I saw you joined the Zoom. How are you doing today?
I'm great. How are you?
I'm doing wonderfully. And one of my agents, Sarah Max, and I Zoomed with Dr. O'Rourke several months ago as we were trying to build our sharing network and meet some providers and healers and doctors around Virginia. And as we like to do at Freedom Hub, we like to feature the more innovative doctors and practitioners out there on our weekly show, which we now have hosted 4 or 5 years every single week, except holidays, including next week. We won't be here for a couple of weeks, well-needed break. And we've had a lot of DPCs over the years, and that stands for direct primary care, which the technocrats in DC, policy wonks, label as monthly subscription care. And some folks might balk at paying a doctor a monthly fee, but the dynamic has taken off over the past several years with families and employees and businesses who aren't stopping that monthly payment by and large. Just as folks who have left insurance for sharing, the persistency rate is above 90%, and they're not going back. They like the arrangement, and we'll discuss why today. Every DPC doctor has a different story. What I find really interesting, the pattern is it all stems from the additional time they get with patients. Something changes in the sacred doctor-patient relationship when they get their time back between the doctor and the patient, because as we all know, in today's corporate model, where all these young doctors are not going out on their own, but instead are accepting employment in hospitals, in hospital systems, and catering to the insurance networks to get the reimbursement. They are hamsters on a wheel chasing reimbursement. And that requires quick appointments, get your prescription, see you in a month, whatever. And, especially when you think of the real epidemic in this country, chronic disease, which affects half the country. And you see them, your relatives at the Thanksgiving and Christmas, and they have all these pills that are taken with their meals. And you're thinking, you need a DPC. I got my cousin on a DPC here in Tidewater, Dr. Tinsley, before he passed away from cancer. And, by the way, he had a sharing arrangement, and we can get into that too. It's equally compassionate like the DPC. It really holds your hand during the crises. But the increasingly sick patients need time. and they need easy access, repeated access, follow-ups, and that can add up in a fee-for-service model. And Dr. O'Rourke runs a DPC in Chesapeake, I believe is where you are. And she's going to tell us her story, why she chose it. A lot of doctors say they want to go that model or get more cash patients, but so many of them don't make the jump. Or they try to remain hybrid, take a few cash patients, keep the reimbursement arrangement. And there's a lot of upside to it. So let's let Dr. O'Rourke, speak for 15, 20 minutes, whatever you want to say. Whenever you stop, we'll just go to Q&A. We're always fascinated. So welcome, Dr. O'Rourke.
Thank you. Can I share my screen?
You certainly can if Jim makes you a co-host.
So I'm Dr. O'Rourke. I'm going to teach you how to save 50% or more on costs of medical care. So primary care should be affordable, but using health insurance to pay for it makes it expensive. Just imagine how much a tank of gas would cost if you had to file a car insurance claim every time you went to the pump. Then imagine how much you would have to pay for your car insurance. Insurance-based primary care practices have extremely high overhead due to the administrative personnel required to process insurance claims. To make a profit, patients are packed onto the schedule months in advance in 10 to 15-minute appointment slots. Doctors spend over half their time on administrative tasks and are more likely to make errors due to the sheer volume of tasks per day. The average primary care doctor has 2,500 patients, which amounts to 25 appointments and 250 calls and messages per day. Sick patients are either scheduled with a mid-level provider or directed to urgent care, so doctors don't get to see their own patients. 80% of healthcare dollars go to insurance companies, and they have no product and deliver no value. Insurance is meant to protect you from financial catastrophe, but when the average family is paying over $20,000 a year for health insurance, insurance is the financial catastrophe. If the true cost of medical care is $2,000 per year, you can see the value of spending roughly half that cost on a DPC membership to take care of 90% of your medical needs. As you can see, the massive increase in the cost of healthcare is directly related to the explosion of healthcare administrators, which coincides with the establishment of Medicare in 1965. The truth is that the system is not broken. It was designed this way to benefit administrative middlemen, and patients pay the price in higher costs and poorer quality. In the free market, the customer wants prices to be as low as possible, while the business wants prices as high as possible, and market forces produce prices which are commensurate with value. However, the recipient of healthcare services is not usually the customer. The health insurance companies are the customers, and they want prices to be as high as possible so they can keep premiums high and have patients feel dependent upon health insurance. The cash prices for medical services have to be set at or above the highest negotiated insurance price, so only if you don't have insurance contracts can you set a reasonable cash price. An insured patient doesn't care about the price of the surgery as long as their deductible is lower than the insurance price. But what they don't know is they may be able to get the same surgery in the free market for less than their deductible. The Affordable Care Act was written by insurance companies for insurance companies. The 80-20 rule means that insurance companies must spend 80% of premiums on care for patients with a 20% profit. It sounds good in principle, but the result is inflated prices. Imagine if you were told that you could only eat 20% of a pizza. If you were really hungry, you would order the very largest pizza possible. And that's why healthcare spending in the US was over $4 trillion in 2020, with a $31 billion profit for insurance companies that same year. The free market gives us the best quality at the lowest price, which is what we look for when we shop for ourselves. Shopping for medical care is no different. When you look at procedures which are elective and not covered by insurance companies like LASIK eye surgery and cosmetic procedures, you'll notice much lower prices than when compared to covered medical procedures and surgeries. When we shop for others, we're more likely to look for a bargain, even if the quality is lower, such as when business owners purchase health insurance for their employees. When we spend someone else's money on ourselves, we want the very best quality regardless of price, which is exactly how we purchase healthcare services when we use our health insurance. And you see the lowest quality at the highest price with socialized medicine, such as Medicare for All. So let's talk about some ways to save money on healthcare using the free market. Health shares are more affordable than health insurance because they're only used to pay for major medical expenses, which is the way insurance is supposed to work. For minor medical costs, you'll save money by shopping around. Direct primary care reduces costs in several ways. First, by taking the time to care for patients correctly rather than relying on expensive testing and referrals. Second, by including all primary care services within one low monthly membership fee. And third, by having a healthcare insider to help you find the best prices. So my husband, Jimmy, is a federal employee with excellent benefits. So he provides health insurance for our family for $8,400 a year, which is much better than the alternative high deductible plan, which was offered by my previous employer. We could switch to Sedera Health Share for half the cost, but then our out-of-pocket costs would increase. This graph compares total medical costs between a platinum insurance plan, a high deductible insurance plan, a health share, and no insurance. Predictable monthly expenses such as insurance premiums and DPC membership are in green, and unpredictable out-of-pocket expenses are in orange. So this is a typical year for my family. We only spent $200 out of pocket in 2021. With both the high deductible plan and Sedera, our out-of-pocket expenses would have been the same as if we went uninsured. So it looks like the best financial option is to go without insurance. Think again. Going without insurance works great when you're healthy, but what happens when your health changes suddenly or when your baby is born with a rare condition requiring intensive care? If we would not have had health insurance when my son Jackson was born, we would have been stuck with over $250,000 of medical bills. Jackson was born on December 23rd, but he stayed in the NICU until January 9th. So we ended up paying a $1,000 co-insurance for hospitalization twice in 2015 and 2016. If we would have been using a high deductible plan, we would have had to pay the $6,000 deductible twice. The $5,000 initial unshared amount with Sedera would have only been paid once. So if you look at both our best and worst years, Sedera Health Share is the best financial option overall. Patients get tremendous value from direct primary care. On average, my patients have 3 in-person visits, 5 telephone visits, and more frequent communication by email and text each year. If they were getting this care in the system, they would be spending around $5,000. In addition to savings, my patients also have continuity of care with a physician they trust and the convenience of getting care from their home or workplace instead of being forced to get questionable non-physician care from an urgent care pharmacy or insurance-based telemedicine. This is a patient with diabetes, hypertension, hyperlipidemia, and history of stroke who saved 97% on medications just by switching from brand name to generic and finding the cheapest pharmacy on goodrx.com. My patients save up to 96% on labs. You can save over 80% on imaging by going to an outpatient imaging center rather than one affiliated with a hospital. Due to rushed visits, insurance-based PCPs refer over 30% of their patients to specialists, and most of these referrals are unnecessary. I only refer 5% of my patients to specialists. When I need an intellectual consult, I utilize a physician-to-physician consult to save my patients time and money. And when my patients need to see a specialist for a procedure or surgery, I refer to direct care specialists whenever possible to keep costs down for my patients. Here's some examples of how I help patients save money on testing for sleep apnea, screening for colon cancer, and treatment for skin cancer. And in the past year, I've diagnosed 2 patients with basal cell carcinoma on the face. I gave them both several options, discussing the risks, benefits, and costs of each. One patient was not worried about the cosmetic result, and he chose the least expensive option, which was to have me remove his skin cancer at no additional charge. His only cost was for the biopsy. He ended up with a small scar, which you can see there on the left, and he only paid $50 total for his skin cancer treatment. The other patient, you can see his dermoscopy there on the right. He opted to see a direct care plastic surgeon for basal cell carcinoma on his nose, which had recurred following Mohs surgery several years prior. Mohs surgery can cost up to $12,000, but he had insurance at that time. He had a beautiful result without any visible scar for only $600. Both patients had clear margins, meaning that their skin cancers were fully removed. It's usually possible to save over 50% on major surgery. In fact, cash prices for surgery are often less than insured patients pay due to high deductibles. One of my insured patients flew to Oklahoma City for gallbladder removal surgery and paid $6,836, and that included all pre-op and post-op care. And another insured patient paid $4,200 for umbilical hernia repair surgery at the Monticello Surgery Center in Charlottesville, Virginia. And these are some other examples of surgeries at those two surgery centers. Here's an example of one of my patients, 40-year-old female with hypertension. She states that she's healthy and never goes to the doctor. She takes only one medication for her blood pressure, and she ended up saving $1,564 or 55% with DPC. And if you compare her insurance options, she would save the most with direct primary care without insurance, but it's a safer bet to combine DPC with a health share to protect against unexpected high medical costs. DPC helped this patient to save on out-of-pocket expenses, regardless of whether she had insurance, a health share, or remained uninsured. Here's another patient, 58-year-old male with multiple chronic medical conditions, and he was able to save $23,240 or 93% with a direct primary care membership. And if you look at different insurance options for this patient, without direct primary care, this patient blew through his entire deductible with the high deductible plan. And interestingly, he spent the exact same amount without insurance as with insurance. Without direct primary care, his health share didn't protect him at all from high day-to-day medical expenses, and this ended up being the most expensive option. And once again, DPC protected this patient against out-of-pocket expenses, regardless of whether he had insurance, a health share, or remained uninsured. For my fellow physicians, we all took an oath to first do no harm, and this should include financial harm. I believe that the only ethical way to practice is through direct care, meaning working directly for patients, not for insurance companies or healthcare administrators who would put profits over patient welfare. I believe in charging transparent and affordable cash prices, and I believe in refusing to delegate patient care to those without the proper education and training. For improved quality of care and cost savings, I recommend that all patients pay physicians directly for their care, and this starts with joining a direct primary care practice. And patients may also want to consider more affordable alternatives to health insurance, such as health shares and health matching accounts to maximize cost savings. I recommend all employers offer the option of direct primary care memberships for their employees, since those who take advantage of it will improve their physical and mental health while benefiting financially. Healthier employees are more productive. DPC membership decreases out-of-pocket expenses, regardless of whether the employees have health insurance, a health share, or remain uninsured. And I recommend that employers consider offering their employees affordable alternatives to health insurance, such as health shares and HMAs. And if I were in charge of healthcare in this country, I would redesign it as a free market system, allowing patients to make their own medical choices in terms of both spending and care. And taxpayer dollars would be spent on a safety net for indigent populations and for catastrophic medical expenses. I would allow pre-tax contributions to HSAs without the requirement of a high deductible insurance plan. I would allow HSAs to be used to pay for direct primary care membership. I would remove all penalties for remaining uninsured, especially for Medicare eligible patients. If insurance premiums were no longer allowed to be paid with pre-tax dollars, the insurance market would collapse and the average annual cost of care per person would drop from $10,000 to $2,000 by eliminating administrative waste. Tax dollars would be better utilized by subsidizing HSAs for low-income individuals and by providing catastrophic care for those whose annual medical costs exceed 15% of their salary. So that's it. What questions do you have?
That's great, Emily. Jim, if you want to stop her screen share, we'll go to questions. What about the out-of-pocket help recommendations you made? You mentioned the health matching account.
Mhm.
What information do you have on that?
So a health matching account works just like an HSA, but they're post-tax dollars. So you don't get that additional tax benefit that you do with the HSA, but you are allowing yourself to be your own insurance company by putting away those dollars that you can then say if you have a health share, you could use that to pay for your initial unshared amount if something unexpected comes along. The special deal with the HMA is that your money doubles over 3 years. However much you put in, if you have it for a whole family, and if you choose a higher amount HSA, there are fees associated, which is how whoever's managing your HMA gets paid. But you can have a pretty small individual account that has no annual fees. So
Yeah, if I could expand on that.
absolutely.
I was one of the earlier health insurance agents promoting the HMA. It was a big argument on LinkedIn between HSA people and HMA people, and I saw both. But with DPC people, the HMA is a safer tool to have for out of pocket until they fix that tax law. You can use HMAs to pay for the DPC monthly benefit.
You can, but then your money won't double in 36 months time because you have to leave all your money in to get that benefit.
You do, but once you do get that doubling over 3 years, if you use it, it increases back up pretty quickly.
Sure.
And I'll just show folks real quick here. Let's say you want 10 grand for out of pocket. You're going to have a baby. So you're going to expect some serious out of pocket, or you want an elective surgery, which is going to cost you around 10 grand. Or you just want something for that unexpected out of pocket IUA of 5 grand. If you pay 140 a month, that first month, look at the image, you don't have that in your account because you're subsidizing the pool in the first 6 months. On average, there's different levels of account. By the 8th month, you've paid 1120, but now the value is more than what you paid, 1160. And after the first year, you can see with that green number, 1980, you've got about 12% more than what you put in. So now you can start to use it if you need it. If you have some out-of-pocket emergency, but if you do use it, it's going to just delay the doubling from 3 years to maybe 3.5 years.
Sure.
If you can avoid using it and let the increasing benefits happen in that, especially that 3rd year, by the 2nd year, you've got 5,400, that green number, which is about 28% more than what you put in. And you see there in month 35, you got 10 grand. So that's double of what you put in at 4,900. And let's say you break your leg and have out of pocket of 4,600, that red number, you're down to your month 24 amount of 5,400, which means it's only going to take you a year to rebuild the 10 grand, to basically double it in 1 year. So just a lot of folks are asking. Dr. Korba, another DPC doctor, just asked me if I was going to discuss the HMA today, and I said no. Except that whenever there's a DPC presentation, I always mention the HMA as a great help for out of pocket. So it's good to. You're the first DPC doctor, Dr. O'Rourke, to actually explicitly list the HMA as part of what you recommend. So I congratulate you on that.
I definitely recommend it. I guess I just don't think it makes that much sense to use it to pay for the monthly expense of DPC for a couple of reasons. I mean, the main reason is that you're growing that money, so it's better to take it out, of your checking account, which is not going to be earning money the way that the HMA is going to. And since it's not a pre-tax, since there's no pre-tax benefit, there's no benefit to using that to pay for DPC fees, which are generally affordable.
That does make sense. Yeah, you want to not have to use it if it can grow faster by not using it. So what about the sharing? Do you always recommend Sedera, or do you just recommend sharing in general?
I mean, I recommend sharing in general. Sedera is one that I've learned a lot about. I think I don't want to discriminate against patients that have different religious views. And so unless I already know somebody's religious affiliation, then I won't recommend a specifically Christian health share. I love Samaritan, which is a Catholic health share. So if I know that somebody's Catholic or Christian, I do really like that one. But Sedera is a secular plan. I have a lot of experience with it. I've kind of dove in and explored the way that it works. And I have multiple patients who have Sedera and have used it for surgeries and stuff, and they've had a great experience. But I also have patients with Samaritan and MediShare that have had great experiences with those.
And let me share my screen one more time here. Freedom Hub is funded by another sharing company, Zion. And this is the plan that we sell with DPC. It's called Direct. And it's similar to Sedera, but a little bit more expansive on natural care in terms of treatment options when you get the cancers and heart attacks than Sedera. And you can see why folks love sharing. If you were going to, for age 50 to 65, get a $1,000 IUA, which is Cadillac protection. That's only $295 a month for age 50 and above. You know, if you want to have a little higher out of pocket, then it's $270 a month. It goes up to, you know, $710 for a family, so it can get a little expensive there. And in which case you may want to increase your out of pocket to cut it to $635 for a big family. And then knowing that your DPC is going to cover 80% of your episodes. And if you did want some protection for the $5,000 out of pocket, you could get an $84 a month HMA, which doubles to $5,000 over 3 years. So just add $84 to that $635. So these are the prices. You know, at age 49, the prices go way down. That's based on utilization. So that gives you an idea of what you're paying in total. So $250 on average per person is sharing, whether Sedera or Zion, which we use more frequently now. And your prices, most DPCs average $100 per month per person, give or take, less for an individual, even more for a family. Do you have, are you kind of going through changes yourself on where you're going to charge?
My average right now, when you kind of take into account families and old pricing, is $70 per member per month.
That's great.
I did change prices recently, but I grandfathered in my old patients. So any new patients who are establishing with me now are paying $89 per month if they're under 65 and $119 per month for 65 and up.
So $350 total. If you had sharing for major medical, you for all the primary, that's pretty good Cadillac protection.
It's, yeah.
And so I think we have some questions, Jim. You want to manage that? Jim, are you there?
Yeah, Linda, I think you had your hand up first. Linda, unmute. Are you there?
Question is regarding the cost and your protocol. How do you think to participate by using digital medicine, which I hate, or not?
When you say digital medicine, do you mean things like wearing an Apple Watch and that kind of?
Yeah, everything. You don't have to see the patient anymore. Videos, apps, wearables, all those terrible stuff.
Oh, yeah. I mean, I don't recommend having a completely virtual plan or having it be, you know, a completely digital. I do have the ability to look at people's Fitbits. So I have people share that data with me if that's something they choose to do, or they may be sharing their glucose monitoring. So I think that can be helpful. So if you have a doctor who has more time for their patients, like a direct primary care doctor who can actually help to monitor things like that, or I might have patients who text me their blood sugar every day so that we can be adjusting insulin in real time.
Thank you.
But
Yeah.
but just having someone wear an Apple Watch and think that that's all they need to do, that's definitely not good enough.
Thank you. I
You're
appreciate it.
And a related note, do you have a lot of people with that you help with telemedicine or like a happy hour? Call in at between 5 and 6, on the Zoom, and I'll talk to you. Or
Well, so technically it's not considered telemedicine. The word telemedicine specifically means that that the provider that you're talking to has never seen you in person. So it would be more like virtual care. So I do tons of virtual care for my patients, whether it's on the phone or email or text. Some patients like video chat. So we can do all of those things. I think the happy hour is kind of a cool idea. But basically patients reach out and I help them when they need me. So sometimes there's a delay. If I'm in with another patient, they may need to wait an hour or two to get a message back. But sometimes I'm texting them back just a few seconds later. So I think the fact that people know that I'm there for them gives them a lot of comfort, versus in the system, you call and you wait with the hold music for 15 minutes, and then finally a receptionist gets on and says they'll have a nurse call you back, and you play phone tag for maybe 2 straight days before you ever get anything back from the doctor. Or perhaps they just tell you, oh, you can see the doctor, in 3 weeks, we'll get you on the schedule. It's just not a good system. And there's no way that you can ethically handle a panel of 2,500 patients. I mean, at one point I had 3,700 patients when I was in the system. It's not sustainable.
that's crazy.
Mhm.
Question, Jim.
Yeah.
You raised something with Emily that's intriguing. James Maskell, I think, came up with community care. I didn't dive into it, so I have no idea what he's talking about there, but maybe it's patients with similar symptoms communicating together to brainstorm solutions. Is that what you're thinking of with a happy hour of Zoom calls?
That's in there. Yeah. Obviously, there's cancer groups, different things like that. You could set it up where there's maybe a time slot where, hey, if you have questions, call in. We'll have other people on the call, and also consolidating Dr. O'Rourke's time, so it's not people all day. At least they know where there might be a window that they can get on and talk with you, or a few days a week or something. Yeah.
Yeah, I think that's a good idea. I had this kind of health plan that I did for my patients. I offered it to them for 12 weeks, and each week we focused on something different, like drinking more water or eating more vegetables, getting more sleep. And so, kind of all together, we did this thing and set it up like a competition, to see who could develop these habits and keep them over the course of the 12 weeks. So I think it works with things like that. Perhaps with something like cancer or diabetes, patients may have issues with the privacy aspect, all coming together. And I do have the time that I can sit down with people individually, but certainly that's something that can be offered. I know a direct primary care doctor who does walk with the doc, and so they take a walk once a week, and she has a different discussion topic that they all talk about during their walk. So there's definitely things like that, and every DPC practice is different, and I have the freedom to offer any of these different ideas.
Nice. Steve Alley, your hand was up. Are you still there? Maybe he's gone. Joe.
Yes, thanks. To clarify what this program is, Dr. O'Rourke, are you advising mainly other doctors to focus on this monthly payment approach, or are you advising consumers to seek out this approach? And do you have a website, or can you share the PowerPoint with the details? Thanks.
Yes, well, I mean, I own my own direct primary care practice. So, you know, I'm seeking patients to join my practice, and if they're not in Chesapeake, Virginia, to find a local direct primary care practice just by Googling direct primary care or putting in direct primary care frontier mapper. You can find a list or a map of direct primary care practices in your area. But yes, I would recommend a direct primary care practice for any and all patients. And I would recommend that any primary care physician switch from an insurance-based practice to a direct primary care practice, you know, for their own physical and mental health, and also so they can be the kind of doctor that they dreamed of being before they went to medical school.
That sounds great. Here's one other thing. I mean, I think you've made fantastic points about the free market. And by the way, Mises.org and LouRockwell.com has many great articles on what you're talking about. But what about the case where the person has some specialized, unusual disorder that they need some specialist help or diagnostic approaches for? How would that work in your approach to medicine?
So I still think that those patients would benefit from having a direct primary care doctor in their corner. So you're right that some patients may not do well with a health share kind of a plan if they have very expensive ongoing health issues and have, you know, really expensive medications, need to see multiple specialists. But they still need a good primary care doctor, and you cannot get good primary care with your insurance. You just can't. It's a 10-minute visit, period. So if you have chronic ongoing health issues and you need somebody to be putting the pieces together from all of the specialists that you're seeing, someone who's going to be calling up the specialists and clarifying things, someone who's in your corner, making sure you're actually seeing the physician specialist and not one of their mid-levels, you need a direct primary care doctor on your team.
If I could just amplify that, you know, my cousin who passed away during COVID, he was, you know, chronically ill in many ways, and he was so happy with his direct primary care physician in Newport News. They became buddies. They both had sort of a southern, you know, go hunting background. And my cousin Jim would stop by Dr. Tinsley's all the time. They'd hang out, have lunch, and that improved his health. You know, and he, like Dr. Emily O'Rourke just said, the DPCs have access to cheap labs, cheap meds, cheap tests, and they know the specialist where to go. And you need that care coordination aspect for chronically ill people, and that's half the country now, right, Dr. O'Rourke?
Mm-hmm. But it's not just about cheap. You know, you may be someone who has the best platinum plan, like my family is lucky to have, but those people need a good doctor, and you can't get that necessarily with your insurance.
Yeah, if you're only spending 10 minutes with your primary care physician and they don't know you, I mean, I don't think it's worth much myself.
It's not.
Yeah. Steve.
Yeah, so thanks. I had to take a client call earlier when I had my hand up, so I took it down. Emily, we put a lot of health plans together, and everything we do includes direct primary care for our clients. Do you work with, like in your area, do you have relationships with employers where you try to bring in members in bunches, or are you just kind of doing it one at a time? What's your strategy there?
I mostly work with individuals. I do have a couple of small companies, and I'd welcome small businesses to offer direct primary care to their employees. But mainly, I'm using word of mouth marketing to individuals and to families.
Yeah, that seems to be in all the primary cares docs I deal with. That's their thing is, man, I need to drive membership, and at the end of the day, you need more members. But Yeah, I'll reiterate everything you've said here from the perspective of a health benefits advisor. Placing direct primary care solutions into employers where all their employees have access to a doctor has been a huge thing. If you can get the employer to understand the advantages of it for their employees, it's huge. And I personally belong to a direct primary care practice, so
Oh, that's
what
great.
what you're talking about is exactly spot on.
And I actually recommend that employers don't pay for the DPC membership directly, that they just kind of offer it and, steer them toward direct primary care. Because when patients pay the membership fee themselves, they see the value. So, I have a business where the business pays for it, and the employees sort of grumble about it, like, oh, my employer's cheap, won't, shell out for insurance. It's just this kind of a thing. Whereas my businesses where the members pay, and so it's just taken out as a post-tax payroll deduction, and then the business pays me. Those patients really value it because they've chosen it for themselves. They pay for it every month, although it's through their employer. And so I feel like that's a better arrangement.
No, you're right. That's a really smart thing, because we used to embed them all, but now we've gone to a reimbursement model, just like you're talking about. So the plan is there, and if the employer wants to go out, we'll reimburse up to $70 per month for an individual membership for that employee, and they can choose any DPC they want in the area. So
Choice is important.
yeah.
Hey,
let
to
me-
expand on that real quick with Steve and I have been talking about this. Steve and I worked with you, Dr. O'Rourke, to recruit employers in the Chesapeake area. Steve, in a nutshell, can you what is the package offer for the employers with Dr. O'Rourke and maybe some other DPCs in the area? But I think, Emily, you're the only one in
There's
Chesapeake.
4 of us in Hampton Roads now.
Well, there's
Yeah,
Tinsley
so-
and Newport
I
News.
guess
You in Chesapeake.
I'm the only one in Chesapeake specifically, but there's
Right.
2 in Virginia Beach, and then Dr. Tinsley up in Newport News.
Right. So, Steve, what is that package for the employer with DPCs?
So if we go with the one where it's reimbursable, it includes the DPC membership, and the employee can go choose whichever one they want, and they'll be reimbursed. I think it's $70 for an individual, $120 for employee and spouse, $140 for employee and children, and $160 for family. So, and then they can go join whatever they want. But it also includes any preventive care out-of-pocket cost reimbursements. So even if they have a DPC doc, they may have some lab that costs a little bit, some imaging that costs a little bit for their preventive care. All that's reimbursable through this plan. It has reimbursements for gym memberships, nutrition planning of different levels. It even has vision and dental reimbursements. It's not a full plan, and then mental health as well. So if they have mental health counseling, we'll reimburse up to $3,000 a year for that. So that's kind of the primary care piece. So,
And then maybe
prescriptions.
medical
We use Drexy for our prescription plans. So it's something, if they can't get it at the DPC, they can go to pharmacy and get it at a heavily discounted rate. And then specialty drugs, we work with the DPC docs to get them on manufacturers programs, however that might work. So it's such a small percentage of people that some fall somewhere outside of that you can deal with them one-off.
Yeah.
And it takes all the pressure off the employer's health plan, because now it's not part of the whole claims experience isn't an issue, because then we offer medical cost sharing as one option for catastrophic, or the employer can use an individual coverage HRA to pay a portion of the premium for a traditional individual plan off the exchange that we can get for the employees. So we can take them either direction. So we can build a fully featured plan, but it's all built around direct primary care as the key component.
Is this all for self-funded employers?
No, we have companies as small as 3 people, all the way up to my largest account's got about 350. So we can help them. We can help the larger ones have to meet the Affordable Care Act metrics of affordability. That's what the individual coverage HRA does. And so we can keep them compliant and let the employer get out of the group health plan business and offer great access to care in alternative ways. So that's the strategy.
Okay.
And then we use the HMRA too, or the HMA, HMRA, whichever one they want to do.
Yeah, just a key
Doctor-
takeaway, this is taking on self-funding because
Yeah.
we're using the ICRAs to bring sharing into bigger companies, and the HMA for out of pocket and DPC. And sharing is portable because once you leave the company, it's yours. So
I have a question actually for physicians that might be looking at this and thinking of getting out of the system like you did.
Mhm.
How difficult was that, or what would you recommend as far as moving over to open your own practice? Obviously, med school is not business school. So
Mhm.
how did that all flow for you, and what are your recommendations?
So the technical difficulty is extremely low. So if you think about it, people move to the United States and they don't even speak English and they open their own business. It is not hard to open a business, and somebody with a doctorate degree can open their own business. You don't need to go to business school. So it's not actually difficult. It's all mental, right? It took me 2 years to get over the mental hurdles before I opened my practice. But once I did, my only regret was that I didn't do it 2 years sooner, because my life is infinitely better as a direct primary care doctor. My career is better. Financially, I'm doing better, and at home it's better. So there's really no reason not to open a direct primary care practice, because it will improve everything.
And what did you do I mean, you need patients, right? Members, how did you set that up or bring them in?
Well, some of my patients followed me from my old practice out in Suffolk, so that was far enough away that there wasn't a restrictive covenant. And then one of the things that I did is BNI. So BNI is Business Networking International, where you meet with other business owners and you kind of sell your business to them, and then it allows you to help spread word of mouth. I mean, with a year of BNI, over half of the members of my BNI group had become my patients, and so that was a great word of mouth way to go. I had some newspaper articles, but I mean, it was mainly word of mouth. I do some social media and stuff, but again, you don't have to be amazing at marketing to get enough patients to break even, because again, this is a low overhead model, so you can do it with very little out-of-pocket spending. All you need is your knowledge and a stethoscope. I know direct primary care doctors that do entirely house call based practices, so they don't even have a space. They don't have a lot of equipment, because really what people want is a real physician and someone to spend time with them and to listen and to diagnose them correctly the first time. And then it helps if you have access to some affordable labs and maybe affordable medications. But every DPC practice is different, and you can do it in the way that works for you.
Got it. Beautiful. Thank you.
Well,
Charles Ford.
Yes,
Charles Ford, yeah.
Emily, how many patients does a DPC have before they max out? What's their total workload max?
So it really depends. I know of practices where they have fairly large patient panels, some with 1,200, and they have a more of a high overhead type practice, and they hire more staff to help with all of the logistics and care coordination. I personally have what's called a micro practice, meaning that I don't have any staff, so there are no barriers between me and my patients, and that's the way that I like to run my practice. So I have a 200 patient practice, and with the amount of care that I'm giving, I would max out at 300 in my practice. But again, it depends on how you do it, how much staff you have to support you, and also the level of care that you provide. So some doctors are providing more in-depth care, more coaching and mental health and stuff, and I do a lot of that, whereas others are providing more basic primary care services. So it just depends on the practice.
Okay, one last question, and just to help an old man to understand this,
Sure.
if you can. Where is the incentive for you as the DPC to go downstream, outstream, upstream, and providing these related services and giving access to discounted prices? Where is the incentive for you as the member of the process to do all those things?
It's because medicine's a calling. You know, I didn't go into this to make money. I had the grades that I could have, you know, started my own business and become a millionaire doing any number of other things. And that's what you're going to see when you look at most physicians. We want to help people. That's why we gave up a decade of our lives to educate ourselves on medicine. So that's the incentive. You know, we want to do right by our patients.
Can I say something about what that question and what she's talking about? Because I belong to a direct primary care clinic. My initial consultation with my direct primary care doctor was almost an hour long. She just sat there and talked to me and asked questions, and we had a conversation. She's become a friend because I can call her at any time. She's there. I get in same day almost always if I have an issue. And it's just it's a personal relationship. So what do you think a doctor-patient relationship should be like? So it's just and nobody's used to it. That's the thing. Nobody believes you when you first tell them that. But it's a whole different interaction, I'll say. And every time I go in, my doc spends as long as if I wanted to sit there for an hour and talk to her, she would. So I just wanted to make that comment.
Thank
Kinda
you.
like-
I appreciate that.
Kind of like the bartender model, huh?
Yeah. Well, I mean, people think it's a scam because most healthcare is a scam. And so when they're used to seeing that, they're like, what's the catch, you know? But there is no catch. Doctors hate the system. They hate assembly line medicine. They hate the insurance-based model. So if you can free the doctor from that system, you know, then we're doing what we were called to do. And we love our days.
I'll testify again too with my late cousin, whom I miss dearly. He was bounced around by uncaring doctors in the fee-for-service world because of his chronic conditions. And with the DPC and Newport News, he found a safe space, limitless time and great care until he passed away. So I'm grateful for this market, this DPC explosion. It's critical.
All right, anyone else have questions? Coming up on the end, what do you think, Charles? Should we wrap it up? Ask Emily, Dr. O'Rourke to any final comments and tell us how people can reach you. I do see you put your
Yeah,
Gmail.
I've got the website in there, and I have my email address if anyone wants to reach out if you have further questions.
All right, what's your website again? Just to say it out loud for people that don't.
DowntonDirectPrimaryCare.com.
Thanks. Okay.
And one final pitch, Emily, why is DPC so critical for the future of healthcare?
Because it's the way that you get good care, and primary care is the bedrock of medical care. So if you can take care of 90% of your care for around $100 a month, why wouldn't you do that?